Welcome, everyone. Today is July 7th, 2021. I can't believe it. We're in the throes of summer. I'm Trey Dobson, Chief Medical Officer at Southwestern Vermont Medical Center and an emergency medicine physician with Dartmouth-Hitchcock Medical Center. And this is Medical Matters Weekly. It's a show about the aspects of healthcare that matter to you most. You can submit your questions on Facebook Live, and we have received some questions ahead of time from wellness@svhealthcare.org. My guest today, I'm so excited, is Dr. Jeffrey Parsonet, who is an infectious disease physician at Dartmouth-Hitchcock and the leader of the Post-Acute COVID Syndrome Clinic, which is a location meant to help those that are suffering and enduring with the symptoms of COVID-19. So, Dr. Parsonet, welcome to the show.
Thank you very much.
We're so excited to have you, and we've had your colleague, Dr. Calderwood, and many others from Dartmouth-Hitchcock. Let me just a little bit about Dr. Parsonet. He has a bachelor's degree from Princeton University and then went on to NYU for School of Medicine, internal medicine residency at Yale, and then his fellowship in infectious disease at Beth Israel Hospital and Brigham and Women's Hospital in Massachusetts. You've kind of done the Northeast elite school tour there, Jeff.
Well, I figure I'll retire in Maine and they can bury me in Nova Scotia.
All right, perfect. You've practiced for more than 20 years. You're a professor of medicine at Dartmouth Geisel School of Medicine, and you have several research interests which have shifted lately towards the new pandemic that we're in. But previously, and I'm sure ongoing, you've worked with HIV infection, Lyme disease, and bone and joint infections.
That's right.
So just let's get a little background quickly. I like when I have physicians on or nurses or other medical staff, I like to hear about how they got interested in medicine. So what drew you to a career in medicine?
Well, I have, I guess, sort of an unsatisfactory answer for you in that my two great-grandfathers, who were Russian immigrants, came to this country and went and worked their way through making gloves and hats and went to medical school. And they started the Newark Beth Israel Hospital in Newark, New Jersey. And my grandfather then became a surgeon in Newark, and my father became a surgeon in Newark. So whenever people used to ask me, what are you going to do when you grow up? I'd say, I don't know. And they would kind of laugh. I'm the fourth generation, and my sister's also an infectious disease doctor. So it kind of runs in the family.
Wow, that's great. Well, so then tell me a little bit about why infectious disease.
Well, that's a little bit interesting. So when I was a resident, I really didn't like chronic disease. I didn't like things like diabetes and rheumatoid arthritis and congestive heart failure, where things go on. And I really like this idea of infectious disease because infectious disease you treat and either the patient gets better or sometimes doesn't get better, but eventually it's over, right? So right after I decided to go into infectious diseases, this new thing came out, AIDS, we never heard of before. And then hepatitis C became, so now the rest of my life really has been taking care of chronic infections, HIV, hepatitis C, chronic Lyme disease type stuff, and now post-COVID. So I chose it because I thought it was going to be sort of finite management. And now I'm doing this long-term management of patients, which I love.
Right, and those diseases you just mentioned, they do have their acute component, but then they have this sequelae that can last, and we'll talk about that in a little more detail here on COVID-19. But just back in your training, and I've had a couple other infectious disease physicians on the show, and we talk about part of your training, you discuss pandemics, of course, but you don't anticipate being in a pandemic, at least of this magnitude. Talk a little bit about going through your training and then what your feelings when it actually came about. And you can just elaborate whatever you want on that question.
Yeah, well, I'll develop something about this current pandemic. One of my colleagues, Elizabeth Talbot, who is the assistant state epidemiologist in the state of New Hampshire, and January of 2020, when there was no cases of COVID in the United States or one case, she came to my office and said, this is going to be an event of historic importance. And I said, oh, come on, not really,
Right.
And I was wrong, and she was right. This is a pandemic like we haven't seen since 1918 in terms of its manifestations. I'm not an epidemiologist by training, so I don't have any specific training in pandemics. But certainly in my lifetime, we've seen a lot of new diseases. I mean, Lyme disease, it's not a pandemic in the strictest sense, but there are hundreds and hundreds of thousands of cases of Lyme disease. Legionnaire's disease was new in my lifetime. As I said before, hepatitis C, HIV, these are all things that sort of didn't exist when I started and have now become sort of the stuff that we deal with. Globally, the biggest killers, leaving out COVID-19, the biggest killers are malaria and tuberculosis, which we don't see much of here.
Right. So it's almost, as I was reading yesterday, I believe it was, we use the word pandemic to look at worldwide prevalence, but actually rich countries tend to get rid of these infections quickly, and then they just are out there in the poorer countries. And hopefully we're going to learn from this pandemic and focus some of our efforts on those countries. But we could do another entire show on that, and I'd love to hear your thoughts. In regards to the virus in particular, though, I had a similar thing. It happened to not be an epidemiologist that came into my office. It happened to be my son in January of 2020 who said, "Hey, do you see what's going on? This is going to be really big." And I said, "No, it probably won't be that big of a deal." And of course, I was completely wrong and found that out within a few weeks. What about this virus surprised you the most?
Well, I think that's a really important question. And this is a coronavirus. And we've had two other coronaviruses in the recent past. One is called MERS, Middle Eastern Respiratory Syndrome, and the other one was called SARS. And both of these viruses are very similar in their manifestations to COVID. There are differences, but they're very similar. But the big difference is that with COVID, people become infected with the virus and are asymptomatic for a period of time before they get sick, so that they spread the virus during that period of time. And they can even have no symptoms whatsoever throughout the course of their infection and spread the virus. So with something like the flu, when people get sick, when people get infected, they get sick right away. So they stay home from work. They don't spread the virus. But with this particular virus, people are spreading it without knowing they have it for a period of time before they get sick, or maybe they don't get sick at all. And that is why it has been a pandemic, because the only way to stop it is to isolate people, isolate everybody, so that it's not spread from person to person. That's been the big surprise.
And that probably just gave you chills once you realized that, because you worked with HIV for so long and still do. And that's another problem with HIV, that asymptomatic period allowing for the transmission of the virus. And I think people are understanding that now in the public. But back in the spring of 2020, that was a shock and a big surprise.
And look, it's interesting that last year, there was almost no influenza in the United States, almost none. And why is that? Because everyone wore masks, isolated, right? But so for influenza, that works, but we still had COVID because it's so contagious in that period of time before people actually get symptomatic.
Right.
I think the other interesting thing about this virus that we're learning about, and which is the subject of today's talk, is how even when it's over, it's not over. You get, in many cases, you get the flu and you get over it, and you get other viruses and you get over it. But with this one, for many people, you're just starting.
When did you first realize that there were going to be these longer sequelae?
Well, that's an interesting question. And I have it's a personal thing for me, because last March, so March of 2020, I have a niece who's a healthy 36-year-old who's a nurse at Vassar Hospital in Poughkeepsie, New York. And around that time was the first massive outbreak of COVID in New York City. And there were so many patients that New York City patients were being shipped out to, New York suburban areas like Poughkeepsie. And Vassar Hospital became a COVID hospital, and they didn't have enough PPE. And my niece got COVID. So she was not, she felt terrible, but she wasn't that sick. She wasn't sick enough to be hospitalized. And after a week, her fever mostly went away. But then she tried to go back to work. And when she'd walk up the stairs, walk in from her car, her pulse would go to 160. And she'd walk into the nursing office to go to work, and her temperature would be 100, 101. And this went on for week after week after week. And she was not able to go back to work for 3 months. And nobody had ever heard of, I had certainly never heard of anything like that. She had what was then not really understood, but now we call long haul disease or post-acute COVID syndrome. That is, symptoms persisting for many weeks, often months, after recovery from the acute viral stage. The virus is gone after a week or 10 days. It can't be recovered from people, yet the symptoms go on and on. So that's how I first became interested in this a little over a year ago. And then last summer, we started hearing reports of this on a wide scale from New York City, especially, which were the brunt of the initial outbreak. And it became of interest to everyone around then.
Sure. And boy, we're going to just dive right into this. From a pathophysiology standpoint, is the thought, I know we have a lot to learn, but is the thought that this is an inflammatory response, your own body's immune response that's causing these symptoms to occur way after the virus has been cleared?
Yes, it is. But, despite the fact that, the best minds are working on this, the pathophysiology is really not understood. It's not because it's not just a systemic inflammatory response, because people don't always have the lab tests that show inflammation and they don't have fever necessarily, but there seems to be something immunologic about it. There's a couple clues to this. One clue is that post-COVID, I'll call it post-COVID syndrome, I might call it long haul syndrome, is much more common in women than in men. And women and men have different immune systems that have evolved over, our period of evolution. And in the patients that we're seeing here, I would say just about 80% of them are women. And it's not just as some people say, oh, because women are more likely to complain about their symptoms or whatever else, or men are more stoic. There's a real biological difference. And that implies that it's an immunologic phenomenon of some kind, that the body remains revved up in some way, and that's responsible for the symptoms. But we really don't know. We really do not have a good answer. Some people have speculated that the virus is still hiding out somewhere. Some people have speculated that there's little pieces of the virus that are still around. And it's surprisingly unclear as to what causes this.
Right. It's so elusive right now, but we remind ourselves and others that we are in the very early stages. It's only been about 20 months since this disease was known to the world, maybe a little bit longer from its origins. And so we will learn more over the next year. And in fact, that's part of what you're going to be doing with this clinic, which I'll go into in 1 minute. I just wanted to remind the audience, and maybe you could comment on this, Jeff. Almost all diseases in infectious disease, there is some small percentage of people that will develop some type of systemic inflammatory response and have symptoms afterwards, whether we're talking about streptococcal pharyngitis, the typical strep throat, versus even influenza. But this seems to be different in the prevalence of the numbers of people, the percentage of people that have developed some type of symptom way past when the virus should be gone.
That's right. We're talking here, it sort of depends on how you define post-COVID, whether you're saying symptoms that go beyond 4 weeks or beyond 8 weeks or beyond 12 weeks, and whether you count as a symptom, things still aren't smelling quite right to me, right, versus I can hardly walk, I can't go to work, which we're seeing a lot of. So you'll see widespread numbers from anywhere from 10% to well over 50% of people still are not right at least 2 or 3 months after having recovered, which is a surprising number, since we all know that some people get COVID and have no symptoms or minimal symptoms. Some people have COVID and get all better in a couple of days. So it's really quite striking that such a large percentage of people are still not right after a period of months.
Right. And, one thing about it's difficult. And even for the individual who's aware, hey, I might not really be feeling these symptoms. This may simply be due to me, the anxiety of being through this illness. But when you start seeing actual diminished exercise capacity and other things that can develop, we realize, boy, this is real. And as you said, it can affect a large percentage of people. So tell us then a little bit about what symptoms that you're aware of that you see, other than what you just talked about feeling tired, because there's the buzzwords in the media that the audiences have heard is brain fog and heart problems. And can you just go into some of those?
Yes. So when we started this clinic, we know that the virus gets in through the respiratory tract, right? And that the things that cause most severe illness acutely and cause hospitalizations and deaths is respiratory infection, pneumonia, and things like that. So when we started the clinic, the first person I called was one of our pulmonologists and said, we're going to start this clinic. I hope you're prepared to see a lot of patients. But we were wrong about that.
Oh,
because we've had very little of that out beyond the first couple of weeks. The lungs get better. And what we're seeing in the vast majority of cases is neurologic or what we call neuropsychiatric symptoms. And by that, I mean fatigue, but it's not just fatigue. These people are, many of them are exhausted. I have someone who's a nurse practitioner who works 60 hours a week. And she says, now I have this and I have to take a shower in the morning. I have to take a shower in the evening because if I take my shower in the morning, that's it for me for the day. I really can't do anything more. It can be that severe. So it can be profound fatigue. And then brain fog, by which people mean I can't remember why I came into this room, which happens to all of us as we get older, but it's really worse. I can't do numbers. I can't remember names. And it's much worse than just, what a 60-year-old start to get, right? I've been driving through my town in my car and I can't figure out which way to turn from my house. And then accompanying that, but separate from it, are psychiatric symptoms of anxiety and depression. And it's not just that people are depressed because they can't go back to work or because they're anxious because they're out of work and they don't have money. There's some central thing that's happening that's causing anxiety and depression. And the whole way this occurs is not really clear, but what seems to be happening is the virus, which gets in, through the nose and the olfactory nerve, which is right there, goes right into the brain, is the virus is getting into the brain and in some way causing things to be disorganized. And you get anxiety and depression. You also sometimes have other kinds of nerve dysfunction, neuropathy. And one of the ways that this manifests is in something called long expression postural orthostatic tachycardia syndrome, or POTS, where people's, we have two parts of our nervous system, the part that controls muscles that we can do, but also all the stuff that goes on in the background, heart rate, blood vessel tone, breathing when you're not thinking about it, the autonomic nervous system. And that seems not to be functioning properly in many patients. And that can cause cognitive dysfunction and malaise and other things. So really what we're seeing is mostly neurologic, long-term neurologic side effects from the virus.
Wow. So I just learned something big, Jeff. I thought it would be due to endothelial disruption leading to, ischemia, brain ischemia. And you're saying the virus actually invades in some way the neurons themselves. And I suppose we'll start seeing that in biopsy results?
I'm not sure it's in the neurons or in some of the cells that surround the neurons, the glial cells. I'm not sure that it's neurons. I'm not 100% sure about that. And interestingly, if you do special tests, like if you do a spinal tap or if you do EEGs or if you do MRIs, these things usually come out normal. So there's something happening that's difficult to measure. But it really is a neurologic, mostly neurologic thing. Now we're seeing you asked about the heart stuff. There are well-reported cases of myocarditis, inflamed heart in COVID, but it's really unusual. And we hear about cases of vaccine-induced myocarditis. That's really rare. And from what I've seen, well, there have been, someone's going to point out, there was a death or something, but these are really rare and tend to recover completely. So most of the time, when you do cardiac studies on these patients, they come out normal, which is reassuring.
Right, that's my understanding too. And if they're abnormal, they're barely abnormal and quickly normalized.
Yeah.
And of course, just to remind the audience, you don't hear about it much, but almost all systemic viruses will lead to a very small percentage of people in the U.S. or in the world that have some type of myocardial inflammation.
That's right.
That goes away, even from the flu, for example. So, well, when you mention these symptoms, let me just ask, how does this compare? How do the symptoms of COVID, the post-COVID syndrome, compare with other sort of newsworthy illnesses that have these long-term sequelae, like chronic fatigue syndrome and chronic Lyme?
All right. Well, those are the two that always come up, and it's a very appropriate question. And my answer to this would be, like most of my other answers today, is that we really don't know. One of the differences with Lyme disease, of course, is that Lyme disease is a bacterial infection, and the bacteria are easily killed with conventional antibiotics. And we know that some people, even after successful treatment of Lyme, have long-term symptoms. It doesn't appear to be due to the bacteria being alive. Okay. The chronic fatigue syndrome is really quite similar in many ways. The smell and taste stuff, that's unique to coronavirus. That has to do with how the coronavirus gets in, right? The COVID virus. And but in many other respects, they're probably similar. I haven't seen reports about POTS, this autonomic nervous system dysfunction in chronic fatigue. But my guess is that in studying this huge pandemic of post-COVID disease, that we will learn a lot about chronic fatigue syndrome and about post-Lyme fatigue and post-Lyme disease, and that we will be able to apply things that we learned to those syndromes as well.
The chronic fatigue syndrome, just for my understanding, is that still attributed somewhat or theoretically due to Epstein-Barr virus and other viruses, or we just don't know at this point?
We don't know. We don't know. I think the Epstein-Barr virus thing, not. But in terms of the other viruses, maybe. In retrospect, you can always see things that you didn't see at the time. When we see chronic fatigue patients, we often don't know what day it started, when it started. It was insidious in onset. Whereas with COVID, they were fine, they got sick, and then it went on. So it's a lot easier in that respect to study and to understand than chronic fatigue.
So tell us then a little bit about this clinic and how it operates and what types of staff you have there and what your plans are for the future.
Okay, well, thank you for that. So it's really not what people imagine in a multidisciplinary clinic is having a person come in and sit in a room and have all these specialists come in and listen to different parts of your body at the same time. So first of all, we started this clinic at a time when we were still discouraging people from coming to the hospital. So a lot of our patients we're seeing by telehealth. But what we really have is it's more what I would say is a pathway of care. There's two of us. There's me, and we have a nurse practitioner who recently joined me, Christina Martin, who's also works with me. And we go over all the cases that are referred to us and review their histories, make sure they really had COVID, ask for additional information. And then we do an initial evaluation. And then we have a team of specialists that we've assembled who we then, if necessary, make referrals to. And that team basically consists of psychiatry, including neuropsychiatry for neuropsychiatric testing, and neurology, who does the work on the POTS syndrome, cardiology, which we've had basically no referrals to, pulmonary that we've had some, and then very importantly, rehabilitation medicine, which consists of both physical therapy and occupational therapy, both of which are probably the most important aspect of managing these patients. So we started the clinic barely 3 months ago, and since we didn't know if we were going to get one patient a week or 5 patients a week, we've had about 230 referrals.
Wow.
To our clinic over a 3-month period. We're getting about 25 or 30 a week. And needless to say, that's been quite a stress for us professionally and for my personal life as well. I have to say, it's been really overwhelming. And, we hope it'll slow down soon. The big peak of COVID was in November, December, January, February. So we're now beyond that, and there are fewer and fewer cases. And certainly in Vermont, I think one day last week, there was 1 case or 2 cases of infection. So, hopefully we'll see this slow down, but that's basically what we've been dealing with. And in answer to your question, it's a system of evaluation and then referral to specialists as necessary within our system. And we try to get people seen as quickly as we can, but it's been a bit of a struggle.
Do you, and not to overwhelm you, but for the physicians that are listening here and the other providers, healthcare workers, and the audience, if they believe that they need to be seen or possibly need to be seen or one of their patients, where should they start? Should they start on the web? How should they figure out whether or not this is right for them?
Yes. Well, we like to have referrals from primary care doctors because once we've seen the patient, we would like to be able to make recommendations to the primary care provider. So really, if from the patient perspective, it's best to talk to their PCP and to say, I think I'm suffering from long COVID, I'd like to be referred. And then the referral comes into us. For providers, there are many ways in which people can send us, they can call. We have a dedicated phone number that's on the Dartmouth-Hitchcock website. You follow a couple links and you'll find the phone number, or they can just send in a regular referral form to Dartmouth-Hitchcock and we go from there.
Are you aware of other clinics in New England that are available?
Yes, well, the Beth Israel Hospital in Boston has a very big one, and they've been helpful to us in getting started. I think there are some pulmonologists at University at Fletcher Allen who are doing this, but I don't think they have a comprehensive clinic, and I'm not aware of one elsewhere in New Hampshire, Vermont, or in Maine. You know, interestingly, I'm an infectious disease doctor, and many post-COVID clinics around the country don't even have an infectious disease doctor because it's not really an infection anymore.
Right.
But we had a need for it, and my wife said I had to do it. So there we go.
Well, bless her. That is great. And I imagine it's going to grow despite the fact that the cases have trended down. I think that we will see more cases, hopefully not an expansive number. And then, you know, hopefully what we will see is that these post-COVID type symptoms do dissipate over time, even with no intervention, and not persist except within a small percentage, as you mentioned. So just a couple more questions for you, Jeff. How is your niece doing?
She is all better, or almost all better. It took her really 6 months or so, but I think she's mostly completely recovered.
Great.
As far as she tells me, she's completely recovered.
Great. So you can go back to her morning showers. And then also, what, you know, this is my favorite question of the day. What can you tell people in the audience to help prevent from getting long-term COVID?
Yeah. So here's the really important thing about this, that, you know, every day we hear, there are this many deaths or this many deaths. And people tend to think of COVID as, okay, so there's not many deaths. What people don't realize is that the bigger pandemic here is going to be post-COVID, all right? Because COVID only kills a few percent of people, if that, but post-COVID is a much greater number. And the amount of disability that we're seeing is tremendous. So the key thing about this is to get vaccinated. Okay, people who haven't gotten vaccinated and they say, okay, I'm not going to die. It's a big mistake because the post-COVID stuff, which many people get, is really horrible. You know, so many of the patients we're seeing are disabled. They really cannot function. And you don't read about that in the paper very much, okay? That's not the statistics that the New York Times publishes. They say the deaths and the hospitalizations. So people who haven't been vaccinated, really, they should think about this indication for the vaccine.
Absolutely. And it's very unfortunate hearing about these folks, and they're starting to spread their word to say, hey, listen, this happened to me. You know, it happened to me before vaccine was available, but now that vaccine's available, please don't let it happen to you. Please get vaccinated. Well, we're out of time. I'd like to thank our guest, Dr. Jeffrey Parsonet of Dartmouth Hitchcock Medical Center, as well as Mike Cutler from CAT TV, Ray Smith from Southwestern Vermont Healthcare, and Ashley Jowett from Southwestern Vermont Healthcare. Next week, we're going to have Becca Filson, who is a nurse practitioner, and Lisa Downing-Forget, who is a physician, and they will talk about diversity and inclusion efforts at Southwestern Vermont Medical Center. You can send your questions ahead of time to wellness@svhealthcare.org. I'm Trey Dobson. Go out and find joy in everything you do, even in the face of adversity, and we'll see you next week.